have the last paper for this session, Effect of HPMC in thin cornea less than 400 microns, a 6-month study by Dr. Charuta Shrotriya.
Good afternoon all. My presentation will be on the effect of HPMC on thin cornea, that is less than 400 microns, and this was a 6-month study. So as we know, keratoconus is a chronic progressive ectatic disease of the cornea which is characterized by progressive stromal thinning. Now collagen cross-linking is a novel treatment option to halt progression in keratoconus. It increases biomechanical stability of the cornea via photooxidative interactions. Now, several moderate to advanced cases of keratoconus, they have a pachymetry of less than 400 micrometers at presentation. Therefore, currently a modification in the standard protocol is required. The purpose of the study was to evaluate changes in thinnest pachymetry, posterior elevation and topographic K values after CXL using isotonic riboflavin solution with HPMC in patients with progressive keratoconus and pachymetry less than 400 micrometers. Associated changes like BCVA, CCT and apex pachy were also evaluated, and a statistical analysis was done at a preoperative period and 6 months post-op follow-up. It was a prospective comparative interventional study which included 20 eyes of 20 patients of progressive keratoconus. All patients underwent a thorough ophthalmological examination and measurement of topographic indices and pachymetry both pre and 6 months post-operatively. We included patients who were of the age under 40 years with documented progressive keratoconus and a pachymetry of less than 400 microns. Patients with scarred corneas, any autoimmune disorders, corneal ectasia which was not caused by keratoconus, pregnancy and a history of prior CXL treatment or other ocular surgery were excluded. So this CXL was performed by the same surgeon under topical anesthesia with the epithelium off technique, and the stroma was saturated with isotonic riboflavin solution 0.1% with 1.1 HPMC as the carrier, and primary outcome measures included changes in thinnest pachy, average mean posterior elevation and topographic K values as compared to preoperative values. Additional outcomes included BCVA along with CCT and apex pachy. These are the results. BCVA showed a significant improvement, and thinnest pachy, though there was a slight decrease, it was not significantly, there was no significant difference in the pre and post-operative values. Even with topo K, it remained stable and there was no significance between the pre and post-operative values. Posterior elevation, though there was slight increase, it was not statistically significant, and central corneal thickness also remained stable. The additional Kmax and apex pachy also remained stable with no significant difference between the two, between preoperative and 6 months post-operative. So, standard CXL technique cannot be applied in thin cornea due to safety reasons. So, there are several modifications which have been proposed, such as the use of hypoosmolar riboflavin. But however, there is no standardized procedure for the treatment of thin corneas. In our study, we have used isotonic riboflavin with 1.1% HPMC as the carrier. These are some of the similar studies that we referred to. Though these studies use the same parameters and the same technique, our study differed in the way that we did a 6-month follow-up while these studies were of a short-term follow-up. So in conclusion, I would like to say that at the end of 6 months post CXL, we found that there was no significant changes in the reduction of CCT and thinnest pachymetry and posterior elevation. The Kmax reading showed stabilization after CXL, while topographic K showed almost 1 degree diopter regression, and BCVA remained stable at the end of 6 months in post-CXL eyes. So isoosmolar riboflavin with HPMC is a safe and sustained surgical technique for thin corneas, but further studies with a larger sample and longer follow-up are needed to assess the efficacy before the procedure can be applied on a larger scale. Thank you.
What is the rationale of using this thing?
Ma'am, as I mentioned, the standard protocol that exists cannot be applied for thin corneas because of safety reasons, that damage to deeper ocular structures. So we have to come up with new modifications to the standardized technique, because around 20% of patients of moderate to advanced keratoconus, they present with a pachymetry of less than 400 microns. So for these patients, we have to employ newer techniques. And
What is the role of viscoelastic? I mean, this
ma'am, there is the viscoelastic causes an iatrogenic swelling of the cornea artificially, and as this is also seen in the technique where hypoosmolar riboflavin has been used. But unlike hypoosmolar riboflavin, the increase in thickness with HPMC is not transient, and yes, ma'am, it is not transient, and it forms a precorneal tear film, which also seems to influence the increase in corneal thickness by preventing evaporation.
thank you, thank you.
Slightly on a different aspect, the entire base of your study is that in thin corneas, the cross-linking or the ultraviolet A rays can damage the endothelium, right? So, have you come across any studies before starting this study which has shown that the ultraviolet rays have damaged endothelium during C3R? Have
Yes,
you
sir.
read such human studies?
The study
How
by
many
Wolinski,
studies? Yeah.
Wolinski et al. Has
Yeah.
conducted a study where they proved that it
No,
caused.
were there any cases?
Yes, sir.
So
Damage
what
was
you're talking about is about rabbit eyes,
Yes,
right?
sir.
So they have studied rabbit eyes and they have come across that the endothelium in the rabbit eyes at this particular level of UV radiation concentration, 5 millijoule, the amount of UV rays which reach to the endothelium is toxic to rabbit endothelium. But now, have you read recent studies about it? So there have been recent studies which have been done on the eye-bank corneas, and now people are seeing that these human endotheliums are not, they are quite resistant to these UVA rays, and it might not, this particular radiation dose might not affect the endothelium, and we may not require these modifications. We can go ahead safely in most of the corneas, and now those studies are coming up. I think you should study those papers as well.
Yes, sir.
Yeah.
So
Thank you.
in that technique, you actually you used a layer of HPMC
Yes.
along with riboflavin.
Yes, ma'am. The HPMC acted as a carrier, and that caused iatrogenic swelling of the cornea.
And which protocol did you use? The standard one or the
Accelerated.
accelerated
Yes,
protocol?
ma'am.